I'm Helen Spencer, and I just wanted to let you know my connection with these people and how they're all interconnected. And we're excited today to have the wonderful Professor Dr. Emeritus Willard Bleything here. And he's just absolutely done amazing things, and we've gotten some of them earlier videoed, but he's going to be participating more. But the way they're connected is Dr. Bleything's work and his fame extends far and wide, including to the Yakima Valley. So because of the work he's done here with our disadvantaged kids, at-risk children, and his nice questionnaire and his BEN program, our administrator of the Children's Administration in Toppenish, Region 2, Ken Nichols, was following his work for years. He was a graduate of Pacific University. So when Ken Nichols had the opportunity to have AmeriCorps in one of his offices, in his Toppenish office, doing a child vision project, he knew that it was not only a nice idea, but a very needed project. So we had AmeriCorps for 2 years, and I was supervising the AmeriCorps. And the second year we had 2 brilliant young women, and they did the foster kids. You know, one of our concerns is the foster kid numbers were so high, 44% with unmet vision needs. But they also went out in the community. And one thing they did was to do a screening of Yakima Nation Head Start. And because of Dr. Bleything and Dr. Kenneth Nichols and AmeriCorps, they found Reed Sequactua in Yakima Nation Head Start. And they thought that that darling young child had kind of sketchy eyes, and they sent a letter home. And the father, of course, was happy to have some help for his child, so Reed was in vision therapy, and amazing good results. And we're here to give Dr. Bleything a whole bunch of credit for the good work this child has done, so thank you.
Hello, I'm Dr. Willard Bleything, and I've been passionate about the area of vision learning in my entire career. I'm a retired professor at Pacific University College of Optometry and served as the dean there for 17 years. But I've continued my work there, particularly in the learning disabled children category, even spent a couple of years of graduate work just in that area, studying with the people, the Department of Psychology and the College of Education. And so I want to share with you today some common connections that I think exist between vision and learning. I think it's a good place to begin. We have fancy terms, but I'll explain what they mean. The first one we call accommodation, and it's a word that really means that I can accommodate and refocus from a distant object to a near object. Clearly a task that's needed in the classroom. Something on the whiteboard, write it down please, this type of activity. The other one's called divergence, which means the eye points back and points under and back again. The two have to work together, obviously, otherwise we're in kinds of trouble of making the system work together. The third one is the idea of eye tracking. If I look down at my paper, I need to gather up so much information, and go back to the next line and track very accurately. If I overshoot a little bit, I have to readjust. If I undershoot a little bit, I have to readjust. This takes time. If a person has trouble with eye tracking, they are a clumsy reader. It's just they're walking across the grass and stumbling their feet from time to time to get to the other end. The other area is a little hard to describe. It's called visual information processing. It sounds like I should be talking to a bunch of IT folks at this point, but there's some similarities, it turns out. It's one thing for the print on this page to be nice and clear, and I can see it easily, my eyes follow it, but it's quite another thing for the symbols on this page to make sense to me. So I can get a nice clear image in the back of my eye, that's one thing, and that's what acuity is all about. But what I do with the nervous reaction from that image is much different. So the eye kind of catches light. From then on, it's a nervous process. In fact, the two eyes connect in the middle, radiate, and the visual centers in the back of our head. All of that can go awry. Maybe that's not developed adequately when a child is young. Maybe they sustained an injury on the playground and it's upset because of that. So we call that visual information processing. And in my work with kids, I've discovered that's one of the sensitive areas that keeps them from reading as well as they might. So in the public health arena, we call these risk factors. Risk factors mean put you at risk for some other condition. This term is used elsewhere. If you're overweight, we say that's a risk factor for getting diabetes, for example. If your blood pressure is too high, we say that's a risk factor for having a heart attack. So in this case, these are risk factors for actually having a learning-related visual problem. So we can do some health screenings here, just like you would in other fields, and we do. But there's a bit of controversy on how thorough those might be, and that's one of the major issues that I'm talking to you about today. They should provide early detection, and they should have careful pointers to link it between the health problem itself. So let's talk about that a little bit. Health screenings don't diagnose conditions. They're not thorough enough to do that, but they do identify potential risk factors as to health condition. So that's the business for a screening, identify potential risk factors for health conditions. So it's very important then to design them with really lots of care and to make certain that they identify key risk factors, in this case, leading to early intervention, that meaning visual treatment to get the kids turned around in time. Now, one caution though is that if it's a poorly designed health screening, one that omits key risk factors, it can actually be a deterrent to proper health care. What I mean is it can give a false impression that everything is okay when it's not really okay at all. So if you have a limited test battery, kid passes it, the parent thinks they passed their school screen, everything's fine. That's not really the case. So it must have a thorough enough screening that you have examined all the risk factor areas, things that I mentioned at the start, focusing, urgent, tracking, information processing. Those all have to be part of the screening, otherwise you're going to miss some kids and give mom the impression that everything is just fine. Now, I'm not the only one concerned about that. There's a whole bunch of people concerned about that, and it's gotten some national attention. In fact, the National Parent-Teacher Association has passed some resolutions in 1999 and also 2006, pointing out the shortcomings of the school screening programs now in place. Well, these programs were designed many, many years ago before we knew much about this material, and they've stayed in place, and they're actually controlled by public health departments rather than the school districts. So we can't blame the school districts. We should be looking at improving relations with the public health departments. In addition, the National Association for Colored People passed similar resolutions zeroing in on vision learning in high-risk populations. So it's a public issue, and it needs some attention, I think. And they've been steady advocates for a more comprehensive look at visual function. It's not okay sometimes to just do a limited screening because it gives a parent false impression that nothing wrong with the child. And that's been a real issue recognized by the National Parents Association, PTA, 1999 against in 2006, and they passed resolutions, in fact, outlining the shortcomings of the school screening programs. The National Association for Colored People did the very same thing in 2009 and 2010, well, to vision, learning, and high-risk populations. So it's been a public issue. And these groups continue to be advocates, actually, for development of a more comprehensive look at visual functioning, early development changes in children, and assessments of the key risk factors that I mentioned before, combination of focusing, convergence, moving the eyes from far to near, eye tracking, and the information processing done as well. So these need to be part of the screening and proper referrals made to the right sources. And that's been a bit of a confusion as well. The public health community is mainly consisted of public health physicians who have a really strong background in epidemiology of diseases that pass from person to person and this type of thing, safe water, but the background in issues concerning vision is less prominent in their background. So, but there is a strong literature that we can use on the effectiveness of treatment for these learning-related visual problems, and I point out these are indexed in the National Library of Medicine, so they are for public view. Anybody can access them, and the National Library of Medicine has chosen to make this available to us. So I've contributed to that literature myself a bit and written a paper about some research we did a few years back. And so I want to tell you about that research now because I think it will illustrate some of the points that I've just been sharing with you now. I want to share with you a project that I did a few years ago in Central Oregon. It's an interesting project, and you see all these young people lined up in the row here. They're going to class. It's a special class because it's run by the National Guard. So all of them look like they're in fatigues, and they are. Who's lining them up? A first sergeant, yelling at them, and whatever it takes to get them in line. Very structured. So, anyway, it's an interesting population, and I chose it because they are essentially 100% learning disabled students. They only get into this program because they're high school dropouts, and this is their last chance of getting a high school diploma. They're not delinquents, they've not broken the law, they're not incarcerated, but they're a socially at risk population of youth. That's how we would describe them. Now for a guy in research, it's a perfect sample. They're all on the same diet, they're all on the same routine every day. All those variables are controlled. And so I get to look at them and look at the vision as one of those variables. So let's look at that. The goal of this project is to look at at-risk youth and produce a program graduate the skills and values so that they can see it as an adult. That's their angle. And they focus on grade level scores in reading and math and getting a GED or high school diploma and allowing them to go ahead. So it's a nice goal. It's called the Youth Challenge Program, and actually was started some years ago by act of Congress, and I'll show you that in a minute. It's about a half a year long, and it's all dropouts. They're 16 to 18 years of age, and it's operated in the National Guard in 32 different states. And the program in Oregon has been very successful and been able to garner some awards for their effectiveness. Well, the bigger picture is that we have 10 million young Americans that drop out of school before they acquire any particular productive skills and personal traits to find employment and a better life. This is not good. And at the same time, our nation is facing an epidemic of juvenile crime and delinquency. You put these two factors together, then Congress passed legislation in 1993 authorizing the National Guard to conduct this challenge program. So that's how it got started. It was a concern about delinquency and a part of social science that was not going the way we wanted to. Now, the goal of my particular project, however, was to identify the students who have visual problems and put them at risk for learning disabilities. That's where our focus had been, and design and implement an intervention program that would lower these risks. So in a nutshell, that's what I was up to. Now, we had some outcomes we were looking for, and that was determine which tests are most predictive of visual-related learning disabilities, those means of intervention that might be effective in reducing these risks concerned with learning disabilities, and then create a model program that could occur in places like this to actually correct the problem, address the problem. So these are the methods that we used. The youths were enrolled in this school. There was 123 students enrolled, pretty good size. They were given screenings by our group, and then a comprehensive exam for those referred. Out of the 123, we found 55 who really needed a complete exam. That's a pretty high referral rate when you think about it. So from then on, we put 24 of 55 into a vision therapy group. That is our treatment group. And 31 into a control group. We did this for a period of 12 weeks. We wanted to see if our intervention would make a difference. So we had to look at it against same risk population, but got treatment and so on. The others got treatment later. Prescription lenses were provided as needed because everybody got complete exam. Via prescription lenses, those were provided. Well, the vision therapy consisted of 2 one-hour sessions each week for over a period of 12 weeks. And half the time that therapy was dedicated to basic skills, as we call them, like eye movements, cognitive divergence, focusing the eye, pointing the eye, flexibility, and stereopsis, the appreciation of 3 dimension. The rest of the training period was on a computerized visual program dealing with visual perceptual difficulties. So that was our mix. I was convinced that we had to do the visual perceptual because I was convinced that is key to getting them straightened around. While we were doing this, control group over here was in a structured study hall, so they were having things given to them to do, not just idle time. So now it allowed us to compare the 2 groups. We matched them up, same age, gender, and what we call perceptual test scores. So we wanted to make them equal in that fashion. Both groups were visually at risk. Both received lens prescriptions as needed. So we did pre and post age data, and we pulled those, and we measured the difference between the pre-therapy and post-therapy exams. That was our procedure. We used a device called the College of Optometry Vision Development. That's an organization, Quality of Life Questionnaire. And what the heck is that? Well, our federal government, in its wisdom, and this time it was wisdom, said, you researchers out there, you say you lower the blood pressure of all these seniors. What? So what? Can they do more? Can they live longer? Why is that important to their quality of life? So there was a period of time when the feds were really insisting that you show us your research is making a difference in the person's quality of life. And so this was our attempt to do that. So we have this questionnaire. It's been well thought out, and we use it for that purpose. This shows you a picture of our vision therapy room. Now, in contrast to private practice, we had to train them in a group because we had 8 or 10 kids to deal with each hour. And so we did this. This is myself and a therapist in the room, and they were at stations, so they might be stationed here for some minutes around the room. And we did it, and we did take their own chart notes. So on Monday, they might have said, well, I got to do this many accommodative clippers before I gave out. Next week, hey, I was able to do this many more. And so there was a chalkboard in there. They kept putting their scores in the chalkboard. They wanted to do better than their classmates. So it started a competition of how well I could get my skills up, which was great as far as we were concerned. So anyway, that was the setting. And these are some of the procedures, which are normal procedures you'd find doing vision therapy in other offices. So this has to do with near and far fixations. She's on a balance board trying to figure out where things are on his screen. This is a rotating ball, which actually makes it, and these are prisms, which pushes the ball very straight. And this is an interesting gadget. It pops up and they have to do reaction time to put out the button. So it's a reaction time field trainer. So this is how it came out. Comparisons were made between the group that passed the visual screening and those who failed the visual screening using the symptom scores. We found that the higher the symptom score, the more the problems, and they're weighted. Like, my eyes hurt when I read. Is that sometimes, a lot of times, or most all the time? So there was a weight given that way. And so that allows you to turn things into numbers. So the screen for who passed was 21 points, let's say. For those who failed, it was 33 points. If you talk to statistics people, this is difference is what we call a statistically significant difference between the two groups. So yes, they had more symptoms, they were more severe. Okay. To remind you, all who failed the screening were provided a follow-up professional exam, and it was accompanied by optometrists. In fact, I have to break protocol. This was unique. I have some alums in Bend who loaned us their office over the weekend. And so I recruited 6 optometrists from the state of Oregon to volunteer for this project. The kids were brought up in vans, one van at a time. Over the weekend, we had a marathon. We kept 2 exam rooms going. We had 6 optometrists, 6 technicians, giving very complete exams and got them all examined in that fashion. So a lot of people were involved with this project. So everybody who actually got that exam showed they needed something. So we had 100% accuracy in our screening that they actually needed some care afterwards. That's good. You want that. Afterwards, with the vision therapy group where we intervened, showed an improvement in the symptom score, that is fewer symptoms than the control group, and that was statistically significant as well. So here's some take-home points from this project. Visual screening will be most effective if it includes elements representing those key visual functions that are actually risk factors in learning. That's a gobbledygook sentence, but what we're really seeing is screening has to be designed carefully so that it represents what you're testing, and what you're testing represents your goal. What we were testing is visual factors that impact reading. That was our goal, and we were able to do that. And we found those to be eye movements, two-eye coordination, near-far focusing skills, and perceptual processing skills. So that is the bundle that needs to be focused upon in any screening. A comprehensive exam should follow, because you can point out the problem from a public health standpoint. What's the point of identifying a problem if you have no way to treat it? You don't do that to people. It's called pulling the rug out. So you have to have a way for follow-up to satisfy public health rules. And it's terribly important to select a provider who treats these conditions on a regular basis. They don't all do that. And so that's a very important figure as well. So anyway, those are my remarks. I hope you found them helpful and enjoy this wonderful field of vision and learning.